Hey, good morning. Happy Thursday. Welcome to Quality Leader Session. We're excited about today's content because it's really talking about the infection control strategies as we navigate through the public health emergency. There's so much going on, and there's what can be confusing guidance that we've seen of things that have already sunsetted, things that are ending on May 11th, and programs that we're going to continue forward on that. So what is the role of the healthcare providers as we look forward to navigating these changing times? Unfortunately, Julia Brooks was going to be with us today, but she is not able to join us. So we'll do the best that we can in supporting Julia and covering the content, but not to worry, she will be coming back for future sessions. And we're looking forward to learning about rehospitalizations and even areas of falls and accidents. We are recording our sessions for future review and focus. Feel free to type in any questions that you have in the chat box. And as we talk through, if you have best practices, ideas, or concepts that you'd like to share with us, we would definitely like to hear about them. Feel free to raise your hand or type in the chat box. Chris and I will do our best to monitor these areas to ensure that we have all voices represented and heard. But as we work through this, a lot of our programs are really about sharing what we are seeing, what we're experiencing, and what knowledge that we all have. And that helps to add to the overall field of study. So the more information you can share, the better off we all will be prepared for. Looking ahead, we have navigated up to 48% of South Carolina is at the up-to-date status for vaccinations as reported by NHSN as of March 19th. It's important to note that the White House and CMS are encouraging providers to be at, I believe it's 80%. Is that right, Chris? Oops, you're muted.
85, and I got another list of referrals just a few minutes ago, and all of those folks are in the 60s, but I will be calling you in the next few days, even though you're in the 60s. So yep. That's the desired goal is 85% or higher.
And we recognize that this has been an ongoing challenge for many of us in the industry across the state and across the United States, frankly. We're seeing a lot of burnout and confusion around the focus of the boosters. But it's important that we recognize that in our environments, we know that vaccination helps to mitigate any negative consequences of exposure or contracting COVID or any other type of illness that we have out there. And so while symptoms continue to be very minor, which we're grateful for, there are times where those symptoms do have an impact on our residents, and we are seeing hospitalizations and or people passing away from them. So we want to ensure that we are really working towards those programs. With that, remember, we can only do what we can do. I remember a conversation I had with a surveyor way back when I started as an administrator several years ago, and I had said to her, I'm so concerned about, in that case, it was falls. And I was saying, I don't know how to stop these people from falling, and they're going to fall and they're going to get hurt. And the surveyor said, we can only do what we can do. People are going to make decisions as they need to make decisions. Our role is to educate, to assess, to evaluate, and provide solutions to minimize the impact of the negative consequences of the decisions that are being made. And so what we need to do is ensure that we are providing that education, that knowledge, and talking and being comfortable that we have that information available to our team members. And so it is nice to see that we continue to move forward through this program. It isn't, as in any programs, these are ongoing programs that happen at any facility on an ongoing basis, that we provide education, we provide the resources, and we do those consistent wraparounds. So keep the good progress moving forward. As Chris said, we do get recommendations from CMS to call facilities and check to see if there's any challenges that we can help to navigate through or remove the barriers on. And we will be here to help support you through that. We do see a small uptick happening in COVID cases as of March 19th, and we are hearing across the state that there are hot pockets that are developing, and in those hot pockets we see the need to ensure that we have good proactive measures in place to prevent the spread and contain COVID as much as we possibly can. Chris, I'd like to open it up if you'd like to share anything of what you're seeing specifically.
We we are, have you got the transmission map there? The county transmission map? There we go. So even though, you know, we're looking at this map and we're seeing lots of colors now. And, you know, in just a couple of months ago, that map on the right was completely red. And so we are thrilled to see blue and yellow in there, you know, but we are seeing double-digit outbreaks in centers within these zones that are blue and yellow. And so one of the things that I'm hearing is, well, you know, the community level's down. Yeah, the community level is down, but you've got a double-digit outbreak in your center. And so how can we keep that is not identified in the community from coming into your building? And that all goes back to your traditional source control. And so I cannot stress that enough. And my friend Joel is here with me, and I'm sure that she will tell you that you have got to remember those infection control standards and make sure that those are utilized in your centers every day.
Okay, thank you, Chris. So as Chris pointed out, we are seeing that transition continuing to move forward. We're seeing a nice kaleidoscope of colors coming through on the community transition map, and it's always good to see blue coming through. But it is something to keep in mind that we are still seeing outbreaks happening. And one of the things the CMS has tapped us again from as a QIO perspective is if we see outbreaks that are occurring in facilities, CMS has us calling just to check in to see how things are going, how the programs are rolling, and if you have any questions, I'm working on some action plans to mitigate that potential spread further. So we've talked about the importance of infection control, but let's talk a little bit further about what does this look like as we transition through the public health emergency. We all recognize that the public health emergency is scheduled to end on May 11th this year. These things may change, as things always change with guidance from the government or with new reports that come about. But we do recognize that regardless of the end date of the public health emergency, facilities are still going to be required to maintain infection control standards up to and beyond that date. So when we go back and think about what infection control looks like in the organizations, you know, during COVID, we had this unprecedented amount of directives that we were receiving from a variety of resources and source control agencies, giving us guidance on how to implement standards immediately to mitigate the spread and impact on the facilities. And though sometimes that data was coming throughout the day, I think there was one day where I swear I saw 3 different updates within a few hours of each other of how to change policy and manage to what the changing guidance was looking like. And so we had moved from our previous functions and directives that we had within the healthcare regulatory world of being able to understand the regulatory directives that we had, the minimum standards that we have to meet, looking at our resource agencies and best practice centers for information to help us make these decisions and implement policies. And then based off of our assessment from our expertise, we were able to implement the appropriate policies and procedures to provide care to our staff and residents. When COVID came through, the pandemic came through, we had a lot of information coming to us on what we had to do. We had to do training and testing, training on these topics. We had to do testing based on these criteria in this amount of time frame. We had, there was the directives on putting up walls and taking down walls and what type of validating the type of disinfectants that we were utilizing. There was a lot of directives that we had. And now we seem to be moving back through into that previous focus, the pre-pandemic focus of being responsible to looking at the standards of practice, understanding those minimum levels of expectations, and implementing our policy to that. And that's a hard transition to make. It's really hard. It was hard to go from having our assessment and planning tools in place to being accountable to any notification that was coming out with immediate implementation. And now we're doing that transition back, which I've been referring to in the last 18 months as what was old is new again. We're going back to how we did before the pandemic and being responsible for those assessment skills. So this is a good opportunity for us to just refocus back on that and hold that confidence that we have the skills and we have the knowledge. The information we've gained through the pandemic helps us to build on these resources that we have and implement those interventions. So our regulatory guidance has been updated with phase 3 coming out October of 2022. And we recognize that here's our infection control minimum guidance standards that we have to follow from 880 to 887, with infection control and prevention, antibiotic stewardship, infection preventionist qualifications and role within the facility, influenza and pneumococcal immunizations, reporting through the National Health Safety Network, which even though the public health emergency expires May 11th, we will still be required to report through NHSN at least through December of 2024. We have the reporting to residents, families, representatives, and residents on COVID infection. We also see COVID testing for residents and staff, which has changed. The QSO was changed and updated, so that is something to be mindful of. And then COVID immunization. Looks like Jules also commenting that it is time to strengthen our infection control program instead of loosening it up just because the PHE is ending. That's fantastic. It's really important as providers that we understand what those minimum guidance is. And I'm not sure how you feel, but I feel the last 3 years have just been such a whirlwind. It's difficult to know what was part of the SOM versus what was part of best practice guidance that came through, keeping track of all the QSO memos. I was really struggling with this. And so coming about and looking at how we look at the regulatory guidance and setting our policies in place, I went right back to our infection prevention, control, and immunization survey pathway, the guidance that we use in nursing homes to ensure we understand the minimum level of care. So when we look at those, the survey pathway is several pages long, and it covers all these different topics, understanding transmission-based precautions and standard precautions that we incorporate, hand hygiene, personal protective equipment, resident care for COVID-19, the infection prevention and control standards, infection surveillance, suspected COVID-19 monitoring and what we do if we have confirmed COVID-19, the water management and Legionellas disease and how we look at that program, laundry services, antibiotic stewardships, which is really important and really hitting the news this morning, and some areas of opportunity there. Our infection preventionists, influenza, pneumococcal, and COVID-19 immunizations, staff COVID immunizations, and NHSN reporting, all components within this pathway. And the pathway makes it really easy, although this isn't what we should be just focusing on itself. It does give a nice highlight, a Reader's Digest version of managing and navigating through those regulatory controls and the minimum standards, just so we can get that understanding of that role again. Some of the areas that are important to look at when we look at COVID-19, and back to what Chris was referencing with, we still are seeing outbreaks happening. And even if it's not COVID-19, we still are going to have outbreaks that happen in our organizations. Hopefully not too many, but the risk is there from influenza or norovirus or C. diff. There is always a risk of an agent that's coming about that we have to be mindful of and mitigate that potential impact on anybody else. So when we look at COVID-19, we want to look at what our transmission-based precautions look like. How are we looking at keeping residents within in an isolation or a quarantine space to prevent that spread? That the facility ensures residents who are on quarantine or transmission-based precautions do not participate in group outings, activities, and communal dining. It's also important to think about people going for doctor's appointments. the number of people in my career that I've stopped saying, wait, that person's COVID positive. They cannot go on to that doctor's appointment because they're going to take that illness and spread it to everyone in the doctor's office. That the facility has a plan, including the appropriate placement and PPE used to manage residents that are new admissions or readmissions who have been exposed to COVID-19, so that we monitor them and that we limit that exposure while we work through that quarantine phase. We have a plan to prevent transmission, including a dedicated space in the facility for cohorting and managing care for residents with COVID-19. Cohorting is a really big topic, and we've got some resources to talk a little about that further in this presentation. For residents who develop severe symptoms of illness and require transfer to a hospital or high level of care, the facility alerts emergency medical response and transport professionals of the person's diagnosis. They can be prepared in mitigating the spread to themselves or anybody that they come in contact with in the hospital setting. For residents who need to leave the facility for dialysis, we have to ensure that they wear source control appropriately with national standards. And so this is where the guidance is giving that permission. Maybe permission is not the right word. It's strong encouragement that we're looking at the best practice resources that we have out there, like the CDC. And in response to an outbreak, we need to interview our staff to determine how we ensure that residents are wearing source control to maintain that compliance with our national standards. And so when we have an outbreak of any type of illness, but in this case, we're talking about COVID, we definitely want to do a root cause review to understand where it came from and what our opportunities exist. This is going to help to prevent future outbreaks. So even though we don't really have to produce the documents of the full analysis on where the outbreak occurred, like we may have had to do in 2020 and 2021, it is still a best practice for us to understand how any disease or outbreak is started and transmitted so we can prevent that for future work. It ties back into the quality assurance program and also really relies on the expertise and knowledge of the infection preventionists in the building. On a separate page, we look at the infection control surveillance. And I just wanted to highlight in here that the guidance is directing us back into what the national practices should look like. So our awareness of those resources that we have should continue. We should be looking at our local health departments, and we're so grateful to have the support of DHIC and the infection control team available to us to be able to support us with asking questions or providing resources or helping to work through any transmission concerns that we have. Living in Michigan, that's not a resource that we have here. So it's wonderful to have the great support of our DHIC team to help us with this. We also have our local health departments, we have the CDC, and we're able to help as a QIO to be able to investigate and find resources for you as well. We also want to talk about visitors. So visitors bring a new level of fun to the environment that we have with infection control. We love having visitors in the building, and they do help us with our psychosocial response and make our hearts feel warm. But from an infection control perspective, they can also make you weaken the knees. Thinking back several years ago, pre-COVID, it was time for Halloween, and we were going to do the big Halloween event at the facility, have all of our little ghouls and goblins come through with all their costumes on, and everyone was giving out candy at their doors. And we found out that the school had norovirus. And so having all these wonderful little kids that were coming through the building the night before trick-or-treating now exposed the entire building to norovirus and what we had to work through with that. And so visitors do bring about a level of caution that we should be mindful of. We want to embrace and we need to embrace them in our buildings, but we have to give guidance on how they can do it safely. So we want to determine if visitation is conducted according to resident rights. Are we honoring the resident rights, and are we looking to see how we can manage that, that we can reduce the risk of transmission for COVID-19? And I don't want to speak for everyone, but I'm certain that you've had the same experiences that I have of a COVID positive resident and a family member, and they're sharing the same cookie and they're sharing the same drink. And now in my mind, I'm thinking, okay, so now we have multiple COVID people potential on our hands here, and that person that's sharing that coffee is going to go out, and who knows who they're going to come across on their journey forward. So we do want to ensure that we're educating our community members and that we're helping them understand what risks that they have and what that carries forward to. And it should be in layman's perspective. We recognize that COVID burnout is a thing and it is a challenge that we face, but there is still an ability that we can communicate with people. And one of the things, I had a wonderful nurse explain it to me really simplistically as a non-clinician, that's how I needed to roll. So she just very clearly said to me, think of it like wet paint. Anything that you touch and brush up against is now with you, and everywhere you go, you take it and you dump that wet paint off everywhere else. And so it was a nice way to talk to for me to understand and then be able to explain to non-clinicians, please be mindful, because even though you may not have the symptoms and you may not be experiencing this like other people, there are people that you may come across that will not have that same resilience. And we just want to have that awareness. So here's how we can do this safely. And we give them the guidance as best we can. We want to ensure that we have signs posted so people are educated on this and that they understand what they're walking into or what their experience is. The facility informs those who enter to frequently perform hand hygiene, and we have hand hygiene stations clearly posted and available to them to use while they're there. We also want to limit interactions with others in the facility and surfaces being touched. And so what we can do to help direct people flowing through our building or helping them to get to the appropriate meeting rooms aids in that. Think about some of the places that you may have gone, such as some of these big amusement parks. There's designated walkways and pathways that they're directing us as consumers, directing us through. So how can we direct people through our areas and what makes sense for them so that they know where they need to go and we can minimize the amount of high touch surfaces being engaged. And then also we wanted to think about how we're informing those who enter for monitoring of signs and symptoms related to COVID-19 or any other disease process that we may be monitoring for. Looks like Chris is saying it's important to recall the Omicron has been shown to be viable for as many as 190 hours on hard surfaces. Yikes. So that's a strong virus. And so good to me making sure that we're helping to direct and flow people through the best way we can. Does anybody have any thoughts or ideas on how we can direct or flow people through? Please feel free to type them in the chat box. I went to one center and they had a map that the receptionist shared with the visitors on this is how you get to the room, or this is where the visitation area is. So they could just take a little highlighter and draw it out on the map for the person and hand it off to them. And then any of the as on the pathway through there, they ensured that the signs were clearly labeled and clearly posted, and that the walk areas were clear to prevent touching in or engaging in those surfaces as much as possible. Also, they had another building had assistive devices, like if somebody needed a wheelchair, then we had one at the front desk for them to use, and they were able to transport down to the area, and that prevented them from maybe grabbing the handrails as they're navigating down the hallway to limit that engagement. But we were then able to disinfect the wheelchair at the front entryway for safety purposes for the next person coming in. So as we talked about, it really is based upon assessing the situation. And the nursing evaluation uses API, where we look at the assessment, we develop our plan, we implement our plan, and we evaluate the success of this. In the quality team, we look at the plan, do, study, act cycle. A same concept that we're planning for, we're evaluating, or planning for, we're implementing, we're evaluating, and adjusting to the needs that we have based on our evaluation. That allows us to make the decisions that we need to make. So considering our community transition, if we see, for the example of COVID, if we see that we have increased hotspots in our area, even though the QSO memo says that we don't have to wear masks if we're in the lower moderate areas, we may make the decision that we want to implement that in order to prevent the spread in our organizations. thinking the same thing about norovirus or influenza. If we hear something happening in our community, we may step up our engagement in our cleaning and high touch surface areas. We may do reminders on PPE and how to don and doff appropriately, screening reminders and signage at the door to let people know, whether they be our healthcare providers or our visitors or vendors, so they're aware of what their expectations are in managing or mitigating, especially when we think about the people that, as providers, we don't want to take a disease or a virus. We don't want to take that home with us to our families. So the more information we can provide allows people to prepare for that. We look at cleaning programs. If I had heard of a big infectious disease happening in my local area, or had heard about outbreaks in other buildings, then I was stepping up my cleaning of high touch surfaces and our disinfecting program. We're looking at monitoring. We may do more intense monitoring for symptom changes or conditions that may occur so that we can get on it immediately. And then we look at our huddle and communication process. Huddles are a wonderful tool to be able to start a shift or start a day off and communicate and talk about what's important or what's happening in our area. You may remember a few weeks back, we talked about huddles and the huddle tools that are available on HQuinn. Again, this is one of those what's old is new again approaches. You may have continued with it, but if not, think about how you're using your communication processes and letting your team know what's going on so they understand what to monitor for, how to respond to it, and how we can prevent that flow through. Chris, how we're doing? Are we covering what you're finding?
I'm really thankful that you've touched on these things. You know, when we had healthcare quality on a couple of months ago, one of the things that they talked about was that there were shoulds and shalls in the language, and that in those shoulds, you know, you have some flexibility, and that whatever decision you make for what you do in your center should be based on an assessment of risk and benefit, and that if they come into your center and there are outbreaks in centers near you and your community level is moderate, you know, and you have elected to eliminate masking, then you need to be able to provide them with the documentation to show that you have gone through this and looked at the risk and the benefits associated with that decision. And you need to be mindful of those things that are going on in your community and in your area. Be mindful of the fact that you may have folks in your building that are memory challenged and that they are going to be at greater risk because of that. And how can you protect them? Because you can't change what's going on outside. You can only affect the things in your building. And all of us, I think, will agree that our goal is to protect those people who live there. And so make sure you do your due diligence. Be very mindful of all the risks and the benefits when you make those decisions. So
thank you. That's a wonderful point, because we do have to be able to answer to that. Using our API, we need to be able to discuss how we're assessing and how we're evaluating what that looks like. Great points, Chris. Thank you. So we have a lot of tools available to us, and as we're thinking about it, there's from a cleaning and disinfecting guidance, CDC produces information. We have the EPA list that tells us what the recommended cleaning times are and strengths are for the different chemicals that we have, and what those chemicals cover from a disinfecting perspective. So I like this grid just to kind of keep us focused. And it's not just about the cleaning responsibility of our environmental services team. Cleaning involves all of us. And so whether it's therapy or activities, bringing equipment into a room, hopefully not a room that's in quarantine. We have specific equipment for those rooms. But for other rooms that we're cleaning that equipment between residents, that's going to help us to prevent spreads of other diseases like MRSA or C. diff. That we're looking at how we're cleaning if we have equipment that's being transitioned, or we have to move a resident. Is the room clean? Does the staff know how to clean the room after hours, after environmental services has left the building? Even the example of having the receptionist have equipment available at the front lobby. Does the receptionist know how to clean that equipment and keep it sanitized? Do they have the right knowledge base on it? So cleaning really exceeds beyond just the environmental services team. We should all have a basic understanding of what that cleaning equipment and protocol looks like. A few weeks back, we had the pocket cards that are available on the HQuinn website. This is the example of the cleaning pocket card. And we recognize that it's not a great plan to have pocket cards in your pocket that you're pulling in and out. That is a potential infection control surface. And going back to the wet paint situation, if you've got something, a virus or bacteria that you've picked up on your clothing and those cards are going in and out, now you've contaminated those and everything you touch from there on is contaminated. So we want to be mindful about how we use the pocket cards, but there could be a way to use these, like having them on posted on the cleaning cart. And so the cleaning cart could have the disinfectants and the time that's available for those. We may have them at the nursing stations or on a communication sheet that's laminated so we can wipe it off in between surfaces or in between uses, just as a reference guide or a tool that we have available to us. If you're very high tech, you may have it on a computer system or on your team might be using touch screen devices that you can reference it into that area so that those devices are generally cleaned and wiped down frequently throughout the day and the shift. So you're able to access that information so anybody on the team has the availability. Linking it back to our survey pathways, we recognize that the surveyors are going to be interviewing our staff and they're going to ask questions about cleaning guidance. And so giving our team the safety net to feel that confidence. It's unnerving talking to surveyors at times. Not that you're going to get in any trouble, it just doesn't always feel the best. Our nerves, I think, are worse than what the surveyor brings to the conversation. So having a safety net helps us to have that confidence when we have those conversations. The cohorting plan guidelines. This is a new tool that's been updated on the HQuinn website this month. I think it came out last week. And it helps us to think about how we cohort. Cohorting is not just about COVID. It is about any other disease processes that can be transmitted. So we think about things like how we can use cohorting to contain the infectious agent from being transmitted in a much broader sense. And so we look at things like the space considerations and staffing. And do our staff, we don't have the ability to consistently staff for that specific area because of the number of caseload, do we have our staff that are trained to consistently don, doff, and disinfect appropriately to minimize any type of transmission? It may be from a therapy perspective, if you have someone on isolation precautions, that this is the last person they see for the day, or that we've set up equipment in the room for them. So that's their equipment through that quarantine process that we can then disinfect or discard once they're off of the quarantine. It's the responsibility of all staff to be able to ensure that the infectious conditions are not spread to anybody else within the facility. So we need to be ensure that we're looking at this. And we recognize that cohorting on a specific unit or wing may be ideal, but that may not always be realistic. If you have COVID case on wing 100 and a COVID case on wing 400, you may not be able to cohort appropriately, or you may see that they have already been, we may have already had exposure in those areas. And so you may want to look at how you can quarantine those areas, have the residents safe within those own private rooms, look at removing the roommate if appropriate, but then also keeping that roommate in a manner so that we prevent that potential spread because they have been exposed, potential spread to other individuals. Jewel is giving us a really good point. Don't let census override your ability to isolate new infectious illnesses. South Carolina 6117 states that there must always be a room available to do an immediate separation and isolation. It's fantastic information. So we need to keep that in perspective when we're looking at our structure of our buildings and how we're managing our bed occupancies.
Alyssa,
oh.
if I may, when you're looking at, your cohorting versus, we're hearing a lot of folks say they're defending in place. And when you've got, as Alyssa alluded to, one resident on the 100 wing and one resident on the 400 wing, then you may be looking at a different kind of problem as opposed to a mass outbreak. However, when you do that and defend in place, you absolutely positively must ensure that your isolation precautions are utilized consistently every time. Because when you do that, you are looking at having a staff member or multiple staff members that will go in between positive people and negative people. And I'm not talking about their general sunny disposition. I'm talking about their infectious status. And so that PPE has to be utilized correctly the right way every time. And so if you choose to defend in place, you've got to ensure that you have taken the precautions to know that that will be the case. So I just wanted to throw that out there because that is an area of concern when you are looking at one or two cases over a large building.
That's very true. Thank you, Chris. I think page 2 on this cohorting plan guideline can help you think about how you're structuring this and what decisions we need to think about in cohorting and what our plan is for ensuring the best use of the quarantine and mitigating that spread to the other areas. Some other tools that we have as we're looking at that API method is that we're thinking about our ongoing assessment tools. So the ICAR tool is a great tool to be able to give us a general infection prevention and control focus. As a practice that we utilized my last building as an administrator, we ran a COVID hub a few times in Michigan. And so anytime that we had a COVID case pop up, we pulled our ICAR out and just ran through it, making sure that we had just the general topics covered, and any areas of opportunity that we identified, we then brought into our huddles and brought that communication back forward so that we were ensuring that this was something that we just made that front of mind. In a day that we have where there's call lights and fall concerns and advanced care planning needs and family visits and the circus is coming into the building and they're going to be doing a show for us. All the fun things that happen in a building, it's hard to keep those important components front of mind. And so when we see things that are changing and we're assessing our environments, when we're using our stand-up process and talking about things that are going on, we can incorporate that into our huddle and give that communication out to our team members and pull information from our team members of what their concerns are as well. So we keep that flow of information going and we can all work together to address the needs of the building. SPICE has a really nice tool for infection prevention risk assessment, which is great to pull out and take a look at frequently. Although some of this stuff is done at least annually, think about how you can incorporate this on an ongoing basis and an ad hoc need to address the concerns that you have in the building. The Infection Control Prevention Annual Risk Assessment is available through HQuinn. Our risk assessment, emergency preparedness, and regulatory compliance is a training through HQuinn that's available on the website. And then there's also the necessary infrastructure of infection prevention and healthcare epidemiology programs from Cambridge Core. That's just good to be able to pull back into looking at the IP program as a whole. How is it working? How is it functioning? And do we have the fundamental pieces in place on this? All of these links are in a resource that we'll share in just a few slides. Visitation, so important. And this is a nice uh, flyer to have just to educate our families on being mindful about visiting. So if we are, if you're seeing any symptoms associated with COVID or any other type of symptoms, if we have other infectious agents that we're watching in the area, if you've had close contact with somebody, to let us know, making sure we're washing our hands, we're wearing our face coverings as appropriate, we're covering our coughs, and we're practicing social distancing. How many of us have seen in the last several months with these decreasing symptoms that we have with COVID that people think that they actually have a cold or they're having a sinus reaction or reaction to the allergies, and they actually test positive for COVID. So bringing that awareness up that a small sniffle or a cough can be something that we see leading into COVID cases. Looks like Laura is acknowledging that she's seeing that a lot. There were several times that I've had that conversation with people going, so you had a cough today, huh? And you didn't say anything about it. And you worked all your shift, but then got swabbed before you went home and you're positive. So where were you in the boat? Oh, you went and visited your friends on the other units too. Okay, great. That's a lot of fun. So we're going to be doing some training with everybody again. Just bring that back to the front of mind and keeping that conversation going. We recognize that our teams are doing the best job that they can, and they come to work to care for people and to do the right thing. So it's hard to get frustrated with them. It's hard to get frustrated. It's not impossible, but hard to get frustrated with people that sometimes think they're making the right decisions and end up creating a little bit of a typhoid Mary situation on our hands. So we're mindful about that ongoing education, using those tools available to us. Wearing masks can matter, and this can be so important to us. It protects ourselves and protects our residents. And so using a mask appropriately. This is talking about using source control to protect from the flu, and when COVID is high in the community transition, or we see moderate or high levels in community transition, but then wearing the N95 respirators when we see that we are caring for people that have suspected or confirmed COVID-19. Distinguishing between those masks is important, and then also helping people understand how those masks should fit and looking at the fit testing program. OSHA's been a whole nother agency coming into play on this, but OSHA has been really looking at healthcare providers to ensure that we are properly fitting people for N95s to ensure that we're preventing staff from contracting these illnesses and viruses. The donning and doffing comes about on a routine process. This should just be a part of your ongoing education calendar for the year, how you're bringing this back in and talking about this. At any point in time, we may be donning and doffing for a variety of services or needs. And so it's one of the common citations that we see is F880 for infection control, and donning and doffing and hand washing is right up there as a commonality across the United States. So keeping this on an ongoing basis and having the tools available helps people to be able to do this appropriately. How many times have you seen people wear their masks on their chins or wear masks on their head like a unicorn, or they go to put their mask on and they're touching everything? Those are probably not the appropriate manner from CDC. Not a clinician, but I'm pretty confident it's not in any of the training manuals that you're supposed to be doing that. So we want to ensure that we just give that education, and it's, turn it into a positive. When we can make these trainings fun, when we can include them as part of a staff development program or a staff engagement plan, we may be able to put this as part of a, maybe you have a staff engagement participation where we're asking teams to come up with the best training evidence that they can have on donning and doffing equipment and have some fun with it. And the team that does the best gets $25 or $50 gift card or spotlight in your building. You might be able to do a scavenger hunt with this, or just keep some sort of token or award in your pocket. So as you're doing your walking rounds and your team is walking around, if you're finding people doing it right, highlight them, create a superstar wall. The more that we can focus on the positives and things that people are doing well and highlight that, we build that morale, we build that engagement, we build that positivity and feed people's cups. They've given so much over the last 3 years. We want to fill those cups back up. When we can do that stuff, it helps us. And positive peer pressure is never a bad thing. When you start to see people with a wall of superstars, people want to be involved in it. They want to be on the wall of superstars as well. So build that engagement and excitement up. Jewel also gives us some information, knowing the difference between respiratory protection and source control regarding mask usage. This is vital for respiratory control plan. Jewel, do you want to expand on that further? Not sure if you're
Actually, I'm getting getting ready to drop a link of a little PowerPoint. Well, it's not really a PowerPoint, it's just some differences. I think we get so caught up in thinking we have a respiratory protection plan that's South Carolina OSHA certified, you know, national OSHA certified. But then we have people who haven't had those physicals, you know, and gotten checked off on it. We've had people that aren't wearing the right mask, or we're still in the belief that we can use a KN95 as opposed to an N95 when KN95s do not, you know, support a true N95 protection. So I'm going to drop a little thing here in the chat in just a minute to try to explain the true difference between the two. Because if you're not ticking off all those boxes for a true respiratory protection plan, you're going to be in trouble trying to explain that when it comes to, you know, and I don't practice to survey. I think every day we should practice as it's a survey, but I just want people to understand the difference in what they have in their places.
Thank you so much. That's so critical, and we appreciate the resource on that. Great information. It's see that we have also some additional training. Is actually a great segue into additional training opportunities that we have. So as you're looking at your infection control plan and your infection control going forward, consider how you're incorporating these training sessions into your ongoing education calendars. You may have part of your ongoing education through some sort of subscription service. I know Relias is out there. There's a university program. There's several different out there that I've seen, and I'm losing them off the top of my head, but there's wonderful resources that many companies are already incorporating. But we can also bring in some of these other training sessions to complement this. Project First Line, we were fortunate to have Purity speak to us at the beginning of February. Project First Line has free resources available, and they're not very long. I think this video that's on the screen is only 3.5 minutes or 4 minutes. So that can be incorporated into a staff meeting or a staff development meeting. It can be brought into a huddle. You could have it, again, part of staff engagement, where anyone that completes the training goes into a drawing for the month. So you are able to build that excitement around the ongoing education. And in this case, this video is just understanding the risks in healthcare. Project First Line videos are well put together, well designed, and they're easy to watch. So they're kind of nice to see. In this example, they had, can you spot the areas in the room that could be infectious risks? And it was ping, 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 just popping up on the screen. So they're nice, they're easy to watch, and they're engaging. We also have, ongoing education through the CMS targeted COVID-19 training for frontline nursing home staff. This has been recently updated, and it has a module base that allows us to work through these different modules. The CMS has updated this to also allow for group training. So several years ago, I think it was 2021, if I remember correctly, that this was rolled out, and we were asked to complete the training. I think one of the measures is CMS would like to see at least 75% of organizations to have this training completed at any point in time. It's nice it's not very difficult to navigate through. It's good information to have, and it could be included in your orientation plans. It could be as an ongoing training. Think about how you're operationalizing these ongoing education sessions so it remains part of our ongoing reviews and preparation as we would prepare for emergency preparedness or disasters or fires. Infection control and response to infection control is really important to our organizations. So also think about how it links into your facility assessment. if we're putting on our facility assessment that one of the main areas of concern that we have for risk to the building is infectious outbreaks, then how are we incorporating training to ensure that our staff are competent and trained to respond to these areas? So it ties multiple components together in a program, so we have that ongoing compliance maintained. As I referenced, the infection control programming is really maintaining a presence in the media. And even today, we had Skilled Nursing News publish an article on antibiotic stewardship and infection preventionist role in responding to superbugs. This is a really big push towards being mindful about antibiotic stewardship and how we're maintaining our environments to prevent that spread of superbugs in our organizations. It's supported by the GAO, APAC, CDC, and the White House. All organizations were quoted within the article as publishing findings in the last couple of years, really highlighting and supporting the need for infection prevention. So looking ahead through the public health emergency, this is going to maintain a big component of what we do. Also, McKnight's published to this morning links from the CDC and WHO have both adopted recommendation of a one-time bivalent booster per year at this point in time. Anything can change, but at this point, we're looking at a once-a-year bivalent booster push. So for our residents, we should have them comfortable in recognizing that this is going to help them. We're not doing a new booster every 6 months or every 4 months, or with the new variants that come out. It's trying to make this most efficient and effective as possible. So that's important information as we look forward to changing guidance. We started building our toolkit out over the last several months on how we transition through the public health emergency. And so adding to that toolkit, we included the CDC's core infection prevention practices for safe healthcare delivery in all settings. This has been recently updated to reflect some of the transitions that we have through the QSO. Even if you look on which really has been really nice, if you look on the QSO memo website through CMS or in the survey pathways, if you click on those QSO memos referenced within the pathways, if you go to them, it will tell you if they have been eliminated or if they have been, or they're still continue to be in that revised period of time. So we are able to maintain that as we go forward, that awareness of what's actually still relevant and what has been gone through that sunset period. HQuinn has published the Infection Prevention Program Guide for Healthcare Settings. Much of those tools from the ICAR and SPICE tools are listed in this document, and it came out last week. So please take a look at that. We have the vaccination and booster program review, so tools and education flyers that can be available in an ongoing method. You can incorporate printing out the flyers or educational materials for maybe quarterly updates to families and have that tool available for your resource toolkit. HQuinn has our cleaning, disinfectant, environmental care slides and recording. So if we need to work through and training our team members on being mindful of environmental care and cleaning requirements, we have that available. The NHSN data training is on the HQuinn website from December 12th of this last year, making sure that we're capturing the right and up-to-date information. And our visitation guidance and posters from October are still relevant and still timely. So we can use those posters and print them out or change the different look of them so that it remains relevant and it doesn't become part of the background environment. So I see Chris had a request to talk about MRSA. This is a great opportunity, Chris.
Hi. So one of the things that we have found in our state level meetings is that MRSA has been on the rise in South Carolina. And that is, as you're aware, one of the big, ugly, multi-drug resistant organisms. And so we want to do what we can to help avoid that. The Agency for Healthcare Quality and Research, AHRQ, or Healthcare Research and Quality, sorry, is doing a 18-month program that is free to long-term care centers. And I know when I heard 18 months, I said, are you kidding? You know, but it's not a really heavy lift to do it, and it provides you with education on how to do things within your center, within your everyday workflows. You know, we're talking skincare and bathing type things. It provides educational options every month that provides CEs for not only nursing staff, but also administrators. And so, you know, that's something that most of us are really interested in seeing for both the option of providing better care, but also we all need CEs because we, you know, our licensure depends on it. So I will include that information in the notes that I send over to Alyssa, and include that when it's sent out. The latest validated data indicates that there is an increase, but when you move beyond the validated data and look at the data that's not public yet, it has gone up even farther. And so we need to see if we can get some things in motion to help stem that. And I really look forward to having a number of centers in South Carolina jump on and say they want to take a look at this. So as I said, we will get that sent out. And I do want to tell you, Jewel, I tried to use the link that you shared. And as I am not an employee of DHEC, it will not let me open it. So if you want to send that document over to us, then we can share it.
I was afraid of that as soon as I did it because
Well, if you'll send it to us, we will send it out to the masses.
Wonderful. You know, Chris, what you're saying on the MRSA project, it's nice to know it's not that big of a lift, but that it is having a big impact on our communities. What a fantastic quality assurance project to have as part of your quality assurance plan, and take credit for that. It's free resources, it's relevant information, and aligning with what we're seeing in skilled nursing news and the focus that we have from the GAO, APAC, CDC, and the White House. What a wonderful opportunity to take credit for that. So thank you.
And it will give you a certificate each month that says that you were there and you participated this month, that you can go ahead and load into your plan, so that when surveyors or somebody like that comes in the door, or maybe if somebody has decided they want to, you know, work on a Baldrige award or something of that nature, you've got that information in hand to help document your efforts, take credit for what you do. So yeah, this is a really interesting program, and I look forward to having folks take part in it.
Wonderful. Well, we look forward to getting more information on that. I know that we're coming up on the hour, so I do want to make sure that we highlight next session. We are going to twice a month meetings. That will be the second and fourth Thursday of every month. A new invitation is coming out in the mail next week, so feel free to acknowledge it and accept all those meetings up through the end of October. Even if you're not able to make one of them, at least it'll be on your calendar. So when you are able to join us, you can come into the great sessions that we have planned out. As of next week, the next session on April 13th, Mary Laughlin and Cindy Warner will be joining us from HQuinn to talk about the vaccination programs and ongoing compliance as we look at that. So definitely want to ensure that you have that chance to join us and ensure that we have that part covered. Want to open it up if you have any questions. I'd love to hear from you and answer those for you now. If not, thank you so much for joining us, and we hope that you have a fantastic week. We'll see you on April 13th. Oh, thank you, everybody. Jennifer, we will make sure that we get that over to you. Okay, any other questions? Any other thoughts? Yes, we will be sending the MRSA information out. We'd love to have you part of that. Yes. Okay. Any other thoughts? Any other questions?
I think that may be it.
Well, have a wonderful end of the month and we'll see you in a couple weeks, everybody. Bye.
Bye.